Thanks. Okay, so that's spirometry. Lung volumes are done in a couple of different ways, but the main goal of lung volumes, of course, is like have the person inhale as much as possible and then measure what they exhale and see if the size of that is what we would expect based on the person's age, height, and depending what the norms are, sometimes take into account their race as well. And then the diffusion capacity uses carbon monoxide to determine how well oxygen can get from the alveoli into the bloodstream. So I think one of the most confusing things about reading PFTs personally is the fact that pre and pred are like very similar. And this pre is referring to pre-albuterol, meaning most times when we get spirometry, if we're looking to diagnose COPD, we get a set of spirometry, like we have the person breathe in and blow out, blow out, blow out, measure that before they've gotten albuterol, then we give them albuterol, and then we have them do it again. So oftentimes there's a set of numbers listed pre, and then the percent predicted, and then another set listed post, and then percent predicted. But I think it's confusing, the pre and the pre personally, but maybe other people don't have that problem. Anyway, so this is the predicted value here. So all of these are just based on the person's like characteristics. Before they do any testing, we know what their predicted values are. Then we have them do all the testing, and if we did a bronchodilator, then the post testing would be listed over here. When we're thinking about ILD, we're looking for what on PFTs? Great. Tanner, what would we be looking for specifically? If we're looking for a restriction, what on
Low volume.
low volume? Awesome. So I've lost my ability to click. Oh, there we go. Okay. So low volumes. So the main things that we're looking for are the total lung capacity, which will be listed somewhere here in lung volumes. On our Erlanger ones, it's the first line, so that's easy. For some reason on this one, it's like buried down here, but the total lung capacity. Anything below 80%, we consider abnormal. So if your total lung capacity, like this person, is 62% of predicted, then that is mild restriction. Don't worry about the grading system, but you know that since it's less than 80%, it's considered not normal, it's low. This means that the volume of air that the lungs can hold is abnormally small because the lungs probably either maybe because the patient's obese and for some reason they can't take a good deep breath, or the lungs themselves are stiff so they don't open up well enough. This similar thing can be suggested on the spirometry because the FVC, the forced vital capacity, and the FEV1, the forced expiratory volume, the capacity and the volume, they both indicate volumes of the lungs as well. So the fact that those are low could suggest restriction, but the way to definitely diagnose it is with the lung volumes. So sometimes you'll just order spirometry and the result will say that the FVC and the FEV1 are low, consider getting lung volumes. So that's how we would know for sure if there's restriction. And then the diffusion capacity is often low as well because there's like something thickening the barrier in between the alveolus and the bloodstream. The oxygen wants to get across that to get into the bloodstream, but that's thick or that's scarred or something, so it's harder for the oxygen to get across. So the diffusion capacity will be low too. So we've got our history, we've got our physical, we did a chest x-ray and there's something suspicious, we did our PFTs and maybe there's some restriction and a low diffusion. Often I do a TTE at this point too, just to like make sure I understand the whole picture. But at this point, we're still thinking ILD based on these results. Then what would be our next test? High resolution CT. Bravo, whoever said that.
Can you share your screen now?
Oh, yeah. Yeah. like that.
Oh,
Oh, share my screen. Sorry. I'm not, I do know how to use Zoom. Okay, so high resolution CT. So high resolution CT has a couple advantages over a regular CT. The cuts are smaller, so we can see finer detail, but also they do inspiratory and expiratory images. These are important for some certain things like air trapping, mosaic findings, stuff that is maybe would point us in a certain direction. And then being able to get the CT prone can be really useful if there's a lot of like junk at the bases, at the posterior, and you don't know whether this might be an ILD or is it just atelectasis. So you have the person lay on their front and do the CT that way. And if it's just atelectasis, it should resolve or move to the front. And if it's actually ILD, it should stay. So sometimes that you have to specially request, but sometimes that can be useful if you're not sure. So let's talk briefly about on the CT, often the lobules are referred to like interlobular septal thickening or centrolobular nodules. So what is this lobule that we're talking about? It's basically this unit. So there's a bunch of alveoli making up the acinus and then a bunch of acini making up the lobule. In the middle of the lobule are the pulmonary artery and the bronchiole bringing air in and out of all these alveoli. And then the pulmonary vein and lymphatics run along the outside of the lobules. So this is why if somebody has like really bad heart failure, or just any kind of heart failure, I should say, and so they have high pressures in the left atrium, the pulmonary vein wants to drain into the left atrium, but the pressures are high, then that fluid's going to back up and the pulmonary veins are going to be engorged. And then you might see interlobular septal thickening as a pretty common finding on CT scan that could tell you that. So on a CT, here's an example of like the interlobular septum are here, and they're about ½ centimeter apart. So you can actually see them on CT scan. Whereas anything smaller than this lobule is like too small to really be defined on a CAT scan. So we're just going to go over briefly some like CT findings so that we are on the same page as we talk more. I would like to move, but I forget how to do that. What do I do? Oh, I dragged it. Okay. Okay, so what is this red arrow pointing to? Is a part of the body. Very good. Oh, whoops. What about the yellow area? Okay. And what about the top blue area? I mean, the top blue arrow. Yeah, the pleura. I think I meant for it to be pointing to the interlobular septum, but what about the lower blue arrow? No. Okay, how about the appearance of it? How would you describe that? Okay, Eli, what is ground glass?
It's the glass upside down.
What? Go on.
It's like a fibrotic or like you know, like what you see on the X-ray, the reticular pattern you see on the CT as ground glass.
And what does it mean like radiographically? Does it mean there's like major changes or consult, like is it totally white and you can't see anything? What does it mean like radiographically? Can you say? Anybody? Okay, so I agree it's inflammatory and basically like there's haziness, but you can still see the structures is like what the radiographic ground glass definition is. So you can still appreciate that here's an airway, here are a bunch of blood vessels, but there's like a haziness overlying it, which is different from consolidation, where this whole area, if it's consolidated, would just be like white or gray, and you wouldn't be able to make out within it what's going on. So it means there's not lung collapse in this area, but something's abnormal. So that's ground glass basically. So let's look at, intralobular, yeah, ground glass. Okay, how about, what is the red arrow pointing to?
Heart.
Yes, okay, and what radiographically does that look like, the blue arrow? Also ground glass opacity? Yes. Okay, so it can be the whole lung, like the previous picture, or it can just be part of it. Here, it's very centrally located, right? These are all ground glass nodules, and you can kind of appreciate that they're pretty evenly spaced. So these are called centralobular ground glass nodules because they're all probably in the middle of the lobule. Here are some more examples of ground glass opacities. These are more patchy and more peripheral. And here's ground glass that's more reticular, like Eli was saying, which is more like that lacy pattern where it looks like little tiny fingers of ground glass. And there is subpleural sparing here, meaning there's this little bit that's not affected just under the pleura. And sometimes that's commented on because it has a specific type of ILD that we might think about with that. So what's this then? Does not look like ground glass, right? There's not like a haziness over it. There's just major change to the architecture. No, honeycombing, yeah. So this is lots of cysts stacked on top of each other. Honeycombing isn't just like a few cysts here and there. It has to be in layers coming out from the pleura inward. So that's honeycombing. And then what do we see here? Say that again.
Or like bronchiectasis.
Yes, yes. This is bronchiectasis. What is bronchiectasis in general? Like bronchiectasis, like what does that word mean?
Permanent dilation of the bronchus.
Yes, beautiful. So bronchiectasis meaning the bronchus is ectatic, the airway is dilated. And in some cases, it's because the airway itself isn't normal. And in other cases, it's because everything around the airway isn't normal and it's pulling the airway open. So this is an example of, what's this over here? Honeycombing. And then here's an example of what we call traction bronchiectasis, meaning the bronchiectasis, when something's in traction, like they used to put people in traction when all their bones were broken and they would hang them from the hospital bed in traction. Maybe they still do. I don't know anything about orthopedics. But traction means being pulled apart, right? So in this case, the airway itself might have started out normal. This is not an airway problem, different from in cystic fibrosis where the person gets bronchiectasis because the airway itself isn't normal. In this case, the airway would have been normal, except everything around it is getting fibrotic. So it's all condensing and pulling apart. So this is traction bronchiectasis, meaning the bronchiectasis is a result of the traction. So that's traction bronchiectasis and honeycombing. So if we see these findings, we are concerned. The difference, ground glass, like this kind of stuff here that we see, usually means inflammation, whereas honeycombing and traction bronchiectasis means scarring. This is an important distinction to make. So if we have a diagnosis of ILD, we'll talk about the general management, but we have to keep in mind that inflammation and scarring, inflammation and fibrosis are two different ends of this spectrum that we need to keep in mind which one we're dealing with when we're deciding what to do. That deals with this here facet of the management. Oops. But in general, for all ILDs, you want to do the same approach, which is figure out the cause and reverse it if possible. So if it's a medication exposure, a home exposure, like the person has a bunch of birds or something, you try to figure out what it is and stop the exposure. You give them oxygen if needed, of course, so that there aren't complications. hypoxemia, worsening pulmonary hypertension, things like that. Manage their comorbidities. So a lot of times someone might have ILD, but on top of that, they're also aspirating or something like that that's clouding the picture, making it worse. So we want to deal with that. And then give specific medications if indicated. So here's like a complicated schematic, but basically I like this because it kind of explains how the lung would go from having an injury all the way through having scarring. So this is all the inflammatory process. So we're seeing on CAT scan, when we're seeing ground glass, what we're seeing is a bunch of inflammatory cells either in the interstitium or in the alveoli. And those inflammatory cells, like they think they're doing a good thing, right? Like say the person has like birds at home and they're inhaling all these irritating little fungal particles that come off the bird's feathers. And the lungs think they're doing a good thing by having all these inflammatory cells come in to protect the cells from the birds. But eventually, like it becomes overkill and there's too much inflammation, and the inflammatory cells, they've been in there a long time, so they start to lay down this like extracellular matrix, and pretty soon they're scarring. So the goal is to interrupt this process before they're scarring, because once they're scarring, you can't fix it. You know, scars are scars, whether they're on the skin or on the lungs, you're not going to be able to get rid of it. So you need to stop the inflammatory process before it gets to the point of the fibrosis. So the goal is to like identify what's going on here and try to reverse it before it progresses to here. So the, you know, there's the initial insult, then the inflammatory response, and then the fibrosis. So here is like ground glass, which can be maybe this person, this is an NSIP pattern, which you don't need to know the specific patterns, but this would maybe be related to like autoimmune disease. So maybe this person had scleroderma, they had NSIP, and then for years it wasn't treated and it progressed to fibrosis. By the time it gets here, it's, you know, not really treatable. So that's the progression that we're looking to prevent. So as we said, the first thing to do is identify what this causes. So we usually send a bunch of autoimmune labs, even if the person doesn't have symptoms. So we ask like dry eyes, dry mouth, joint symptoms, stuff like that. Even if they don't have any of that, we still send off the labs because the lung disease could be like the first sign of the ILD. You still want to ask all those questions and do the exam, but just the absence of all that doesn't necessarily mean that they don't have a connective tissue disease affecting the lungs. So we might send off a bunch of autoimmune stuff. There's a hypersensitivity panel we can send because some people are sensitive to things like feathers and such that can cause irritation of the lungs. You get a history, like where are they working and stuff like that. So we identify the pathophysiology there. To target the inflammatory response itself, we often use steroids. That's like our first line for any inflammatory lung process. Often we just use them if we don't know what's going on also, you may notice. But so steroids are supposed to tone down the inflammation. We just reviewed how the inflammation is in there. If it stays in there for long enough, it's going to start leading to scarring. So you need to like reverse that inflammation. Reversing the inflammation often usually improves the symptoms too, because the symptoms are from the inflammatory cells being in there, causing the lungs to be stiff, causing that restriction, reducing that diffusion capacity. So if we can reverse all of that, the person will feel better and will improve the long-term health of the lungs. So we use steroids first, and then we have all these other steroid-sparing agents, and I should have put methotrexate on there as well, which is what we use for sarcoid. So we use steroids first, and then we might introduce another 1 or 2 agents to try to taper off the steroids and keep the other agents on. So this is for inflammatory lung disease. There are antifibrotic medications, and those are used for fibrotic lung disease. So it's important to make the distinction between, does the person have inflammation on their CAT scan, or do they just have fibrosis on their CAT scan? Because there's going to be a difference in how you manage it. So let's talk about, now we kind of get the concept of the inflammation fibrosis situation. Let's talk about specific types of ILD. So there's going to be a second ILD lecture where I'm going to talk about some of these other causes, But one way that people divide up ILD is into known versus unknown causes. And we're going to talk about the unknown causes a little bit today. Then there's also sarcoid, which gets like its own category because like no one really knows what to think of it. And then some sort of random ones. But so we talk about the unknown causes, meaning that they're basically like the inciting problem is idiopathic. We don't understand why it happens. And here's the list of them. IPF, idiopathic pulmonary fibrosis. We're going to talk about it in a little bit more detail because it's sort of its own separate thing. Whereas all these other ones are different types of inflammatory lung disease, meaning they would cause ground glass in all different types of patterns, and you would treat them with steroids and maybe steroid sparing agents. IPF is different though, because it's not inflammatory, it's just fibrotic. So it does not go through that classic progression that we were just looking at of inflammation, like insult, inflammation, fibrosis. Fibrosis just happens in the lung, which is why it's such a difficult and deadly problem. So we'll talk about that one first. So IPF, idiopathic pulmonary fibrosis. It is important when patients will be told that their CAT scan showed pulmonary fibrosis, and maybe they just have like a little bit of scarring in the corner of their lung, but they go home and Google pulmonary fibrosis and they're like, oh my God, I have like a year to live. So it's important to tell them that idiopathic pulmonary fibrosis, if that's what they Googled and found, is a very specific condition, and that's probably not what was meant when someone told them they have pulmonary fibrosis. I have like so many patients who come to pulmonary clinic and they've been told they have this and they're very scared. But they're rightfully scared because if you actually do have IPF, it is a very poor prognosis. So it mostly affects men over 50. It also does affect women, but predominantly men, predominantly age over 50. It's basically unheard of under age 50. So if you're dealing with a young person, you don't think about IPF. It is associated with smoking and is associated with telomeropathies, which we had talked about earlier, or like the advanced aging types of things, like advanced graying, which makes me nervous for Dr. Pamelia, and other things. Here's, I didn't think of that. Here's a graph showing the mortality or the survival, I should say, of people with IPF. So you can look at it like 5 years. It's basically 50% mortality at 5 years. And at 10 years, it's basically 80% mortality. So IPF has a pretty poor prognosis. This is trying to illustrate that the prognosis has improved since over the last decade from when antifibrotic medicines were first put on the market, but I find this like a little bit difficult to interpret all these different colored strands. So IPF, we talked about how IPF is fibrosis. So now we know what fibrosis looks like on the CT scan. It's usually peripheral honeycombing. So here's the honeycombing, here's the traction bronchiectasis, and there may be reticular fibrosis. So here are areas where there's not exact honeycombing, but there is this sort of like lacy white markings, and that's that's reticular fibrosis there. But there's not ground glass. Why is there not ground glass? Because it's just fibrosis. There's not inflammation, right? So inflammation shows up as ground glass on a CT, and it's not going through that progression of inflammation. So it just shows up as fibrosis. The treatment is different because we don't have this classic like injury, inflammation, fibrosis progression. So it's not the same situation where we're just trying to get the inflammatory response under control. We don't know what the inciting thing is. It's idiopathic, like people just start getting fibrosis in the lungs and they don't have an inflammatory phase. So we go straight to treating the fibrosis. So antifibrotic medications, there was a trial back in 2012 that really established antifibrotic medications as standard of care for IPF. And it compared them to prednisone plus azathioprine plus NAC. This trial compared prednisone, azathioprine, and NAC versus placebo for IPF. And these are really, prednisone and azathioprine are really strong anti-inflammatory meds. So people thought IPF, there must be really strong inflammation because there's so much fibrosis. So let's give these really strong anti-inflammatories. And it actually looks like treating with anti-inflammatories was worse than just placebo. So this is why it's important to identify IPF specifically and just treat with antifibrotics and not try anti-inflammatories. They're not going to work and they might make things worse. Yes.
I was going to ask though, with others, if you caught it really late, let's say there's already fibrosis, you'd still see inflammatory changes as well?
Good question. And that's like one of the most difficult parts about like people presenting late with ILD is trying to understand whether they had IPF or they had like scleroderma with inflammatory lung disease, and we just missed it for years, and then it ended up as fibrosis. And it's basically impossible to tell unless there is some ground glass, and then you might think, okay, there's some areas that have inflammation, so this is probably an inflammatory disease that has progressed. Otherwise, biopsy is really the only way to tell the difference. But if the area is completely fibrotic, even a biopsy wouldn't tell you the difference between, is it fibrotic because it's IPF, or is it fibrotic because it's something else, started out as something else and just has totally progressed. So now we use antifibrotic meds, even for something like RA-associated ILD, like if it was, or scleroderma in that example, like if it was from a room issue that they developed ILD and then it progressed to fibrosis, we're using the antifibrotic meds more and more for that kind of patient. It's like the literature is now expanding outside of just IPF. So the antifibrotics that I'm talking about, there's just 2 of them right now, nintedanib and pirfenidone, also called Ofev and Esbriet. And so these are meds, they have a fair amount of side effects, but meds that we put people on when we think they have IPF, because this was this trial in 2019 that basically established that the transplant-free survival is much better, if you're looking at this line, for people who are on antifibrotics. The problem is though, they're basically just trying to prevent more fibrosis. So they don't reverse any damage that's already been done. So the patient comes to you with like tons of symptoms and they're on oxygen, you're not going to be able to get them off the oxygen or improve their symptoms because that damage is done, right? Like the scarring that's already there, the fibrosis that's already there, it's not reversible. You're just trying to prevent more rapid fibrosis from forming. So that's what the antifibrotics do. They just prevent more fibrosis. They don't reverse anything that's already been done. That's why it's so important. Like if this process has an inflammatory phase, catch it in the inflammatory phase, reverse it then, because once the fibrosis is there, it's there. So that's IPF. And then I talked about how there's all these other different inflammatory pneumonias or inflammatory ILDs. There's NSIP, which is ground glass with the subpleural sparing that I mentioned. So it's like basically ground glass everywhere, but not, here's a little arrow showing it's not right on the edge. Cryptogenic organizing pneumonia, or COP, is usually more peripheral and patchy. AIP is similar to ARDS, so it's just bilateral ground glass. Yes, Eli?
Is that like when you tell the patient to prone when they do it?
This would
It
be
doesn't look like it's that very.
totally. Yeah, there are a lot of, not that one, oh, this one isn't either, but a lot of ILDs actually do affect preferentially like the lower lungs. So yes, so it can be difficult to know if that's what's going on or if it's more of the atelectasis. So this would definitely be a patient who you might want to flip over. Okay, so we talked about inflammatory, we talked about fibrotic. Any questions before we go on to a few mix-ups to test our knowledge?
Sometimes like we admit patients, they're like acutely this actually look just like this picture.
Mhm.
And you know, we're trying to figure out what happened.
Yes, so
Is it gonna happen like all of a sudden? Like
Yes.
COVID patients almost not the same pattern.
very true. So this talk, I guess, focused more on chronic, like outpatient ILDs, yeah. But certainly, for example, AIP is the same as ARDS. It's just that we have no idea what the cause is. So like ARDS, we can usually say it's from COVID, or it's from pancreatitis, or it's from pneumonia. AIP is like, it's basically ARDS, but where we can't identify the cause. So as with ARDS, it can just happen with, it starts like within a few days and progresses rapidly until maybe there's like ground glass everywhere and hypoxemia. But so it should be on the differential for an acute presentation with CAT scan changes and hypoxemia if the cause is not known. But yeah, an acute ILD should be part of that differential. All right, exam questions. You all can read this to yourself. Okay, so who can like just give me a clinical summary, like a little, what's like the main thing that's going on with this guy in this situation?
Their IPF is getting worse.
Beautiful. Okay, excellent. That is what I said as well. Progressive oxygen dependent IPF, declining exercise tolerance. Their IPF is getting worse. Well done. So, which is the most appropriate management? Azathioprine, daily prednisone, etanercept, or lung transplant? Okay, what's wrong with azathioprine as the answer for a guy with IPF? Exactly. This is an anti-inflammatory. It's not an inflammatory process. Same thing with prednisone, right? Same thing with etanercept. So these are all aimed at inflammation, and that's not what's going on here. So what is the treatment for this gentleman? Transplant, exactly. So patients with IPF, they are one of the main populations that gets lung transplants in the US. And so that should be considered for a patient who has progressive bad ILD. Okay, second question. Okay, someone please give me a little clinical syndrome here.
Progressive dyspnea
Okay,
with restricted PFT patterns. Maybe
that's a good point. He walks a mile per day.
yeah.
Okay, great. Decrease in exercise tolerance and signs of ILD. He had low oxygen, he had crackles, and he had restriction on PFT. Okay, so the question is, which of the following is the most appropriate diagnostic test to perform next? Bronchoscopy, biopsy, BAL, CPET testing, high resolution CT, or a VQ scan? C, great, because we're suspicious of ILD. We have our baseline testing, our X-ray, and our PFTs. The X-ray might be normal in ILD. So just a normal X-ray should not deter you from pursuing that workup, especially if there's restriction on PFTs, unless you're sure that the restriction is due to like obesity or scoliosis, something else, then you should go ahead and get the CT or refer them to pulmonary. So agreed, high resolution CT.
If we had normal PFTs, would you do the, since we learned about it last week? That worked better. Like, would we do B instead if he has no PFT?
Oh, you did learn about that in yoga. That's true. So,
Yeah, that's very good one.
you might, if you do a really exhaustive workup and you can't identify what's going on, but there's something that makes you think there might be a pulmonary or cardiac limitation. So it's not really appropriate for just like, this person has dyspnea and everything's normal. But if they have like a little bit of diastolic dysfunction or like resting bradycardia, or just like something where it seems like their exercise limitation might be, there might be something specific to identify, you could. But CPET testing, like the person has to get on the bicycle and like pedal really hard. And so like a lot of our patients wouldn't even be able to complete the test. So you usually don't, it's not really indicated for like a person who's quite deconditioned or hypoxemic, because that's just like, it's not going to be a diagnostic test. All right, last one for your perusal. Okay, what is his clinical syndrome?
Sounds like chronic restrictive lung disease.
Awesome. With, we might say like some fibrotic changes on CT. So let's just look for a second at his PFT. So how did you know that they're restrictive?
Ratio is 85%.
Meaning?
So that would be a normal ratio. That
Mhm.
would be,
So no obstruction, right? Mhm. And what else?
the FEV1 and FVC are both decreased.
Perfect. And the diffusion capacity as well. Great. Okay, so yep, signs and symptoms of chronic restrictive lung disease with fibrotic and not inflammatory changes, right? So they even tell you on this question stem, there's bilateral predominant septal line thickening. So that's that like reticular pattern of fibrosis, and then evidence of honeycomb changes at the bases, but no ground glass. So it doesn't sound inflammatory. And he has chronic signs such as clubbing. And so here's the question: which of the following is most likely? Why not COPD? Not obstructive. Wonderful. Hypersensitivity pneumonitis is an inflammatory ILD, so doesn't really fit with the changes on his CT scan. And respiratory bronchiolitis associated interstitial lung disease is also inflammatory. This is an inflammatory lung disease in active smokers, so it doesn't fit because he's not an active smoker and he doesn't have inflammation. So, yeah, right? Okay. Thank you.
Oh.
Questions, comments?
At a high level, are there any others we should be thinking about that are not inflammatory interstitial lung diseases? Or when we see a question, should we immediately hop to IPF?
Yeah, good question. So if there is a question stem and it has some type of description or picture of a fibrotic lung like this, then I would go right to IPF. There's nothing else other than, like you asked about before, other than something that has progressive fibrosis, which should be in the history, because otherwise, how could you know? Otherwise, think IPF with if they describe or show you changes like this. Great, thanks.
Thank you.
Should I end the meeting?